Hello, I'm Dr. Ken Lessons from Keystone Urology. In a moment, you're going to see some presentations from our partner practice, MidLantic Urology. If you're looking for answers, insights, or expert advice, please sit back and enjoy the presentations. You've come to the right place.
Good evening. I want to thank you, everyone, for joining us. It looks like we've got a couple more people trickling in. I'm just watching the head count here. We're going to get started, though, but I'll kind of move slowly for those people that are coming in. So for those of you that don't know me, my name is Greg McMahon, or Dr. McMahon, and I'm based out of two offices at MidLantic. Chiefly, I'm really out of the Wynwood office. That's where I see patients and operate out of Lankina. Then I also do some procedures over at the Bristol office on Thursday morning, where I probably have interacted with numerous of you that are on. My background, went to medical school originally. Well, backing up, originally I'm from Massachusetts, but came down to the MidLantic region for medical school, and then did my residency in South Jersey. And then went back up to New England for a fellowship in urological oncology. And ultimately, my wife's from this area, so we kind of wanted to settle back down in this area. And it's nice too, New England's nice, but it gets pretty cold in the winter. MidLantic, you still get all 4 seasons, but the winter's a little bit more abbreviated. Plus, you get some good sports teams currently, so we'll also try to be done this so everyone can watch the Phillies as well. My specialties, I treat mostly urological cancers. So when you're thinking about the urological system, that's going to be starting with the adrenals, which is the top of the kidneys, the ureters, which is the tube that connects the kidneys to the bladder, and bladder cancer, prostate, which is what our topic is tonight. And then you're talking about penile, urethral, and testicle. So getting a little bit more into prostate cancer, the first thing that's important to understand is what is the prostate. So the prostate's located in front of the rectum and underneath the bladder, as I kind of previously mentioned. And it's really an organ for reproduction. I don't know if you guys can see my mouse here. Hopefully you can. If not, I'm pointing towards something called the seminal vesicle. That seminal vesicle, that's where a majority of a man's ejaculate will come out of, and you can see it kind of has a tube that connects to the urethra. The prostate also will secrete some extra fluid into the semen, and that helps to fertilize the egg and lead to reproduction. And our race or our humans' existence, propagating. Kind of surrounded down in the pelvic region, the prostate is surrounded by a lot of nerves and blood supply to itself and other organs as well. And that's why whenever you're talking about treatment for prostate cancer, you're always wondering about, how will this impact a man's ability to obtain and maintain an erection. And we'll get a little bit further, more into that as we go on in our talk. The size of the prostate, this is really hard to summarize. So as we get older as men, prostates typically enlarge. Now, there's 2 issues that typically occur within the prostate. And the way to understand that is, any patient of mine, you probably heard this, so I apologize, but think of the prostate as an orange. We have the outer orange peel and then the meaty interior that you consume. Prostate cancer typically occurs in that outer orange peel, whereas the urinary symptoms attributed to BPH, or benign prostatic enlargement, occurs in that meaty interior. When we're talking about prostate cancer, it can happen in men with large or small glands. And so size, it plays a role into a little bit of how we treat it from a surgical standpoint and certain things that we do when we're getting ready to complete the surgery. But as far as a risk standpoint, we do take in size when we're looking at your PSA. So if you have a really small prostate, let's say that the average size for most men is about 45 grams, but say if a man had a 20-gram prostate and their PSA was 5, that would actually be a high PSA density. Whereas if a man's PSA was 5, but their prostate was 100 grams, when you factor in or control for the volume or how big the prostate is, that PSA is actually a little bit lower, or that PSA density is lower and not as worrisome. So that's how size kind of plays into a prostate cancer screening when we're interpreting the size of your prostate as well as the PSA value. Some very kind of statistics from a 30,000 foot view. Prostate cancer is the second most common form of cancer among men, the first being skin cancer, and it's the second leading cause of cancer-related death in men. The average age of diagnosis is about your mid-60s, 67 is listed here, but it can be diagnosed younger. I think the youngest man I have in my practice is in their mid-40s, but they really have a strong family history of prostate cancer, where they have certain genetics that are positive, and you can kind of actually see it kind of be tracked through their family lineage. Early detection, so if we catch the cancer when it's localized to the prostate, that is associated with better outcomes. Really what you're looking for there is overall survival, or how long you live after you've been diagnosed. There's about 240,000 new cases a year of prostate cancer. Again, it's the most common non-cutaneous form of cancer diagnosed in men, and 1 in 8 men. I usually say it's more 1 in 7 is the stat I use, but still pretty similar, will be diagnosed with prostate cancer in their lifetime. So this slide, and just to kind of take one step back, these slides were made for all MidLantic and our bigger parent company, Solaris. So there's, I did play a part in creating them, but there's some of it that I think, we need to tweak as we go through these a little bit more, so bear with us. But, what is prostate cancer? Probably the first question to ask is, what is cancer? And remember, there's multiple different types of cancer. You can get cancer from your head to your toe. And cancer is really just an abnormal cell growth pattern. And to kind of quickly summarize what you learn in medical school and undergraduate is that, during the cell cycle, so think about your hair or, your skin, it's continuously growing and changing over. All your cells do that, though. And there's certain controls within each cell of your body, either things that accelerate growth or things that kind of act as a brake on the system. Now, if either the accelerator gets stuck down or the brake gets stuck up, meaning that you're not putting the brakes on, that can lead to abnormal cell proliferation or growth or division, aka cancer. Now, adenocarcinoma, when we're talking about adenocarcinoma, you're looking at glandular tissue. So you can have adenocarcinoma of the colon, you can have adenocarcinoma of anywhere that has glands, like the prostate. So when we're diagnosing a man with prostate cancer, typically it is adenocarcinoma of the prostate. And that's something that you'll probably see on your pathology report. There are some other types of cancer that can occur in the prostate, but they're incredibly rare and not something that we see a whole lot of. If you see maybe a dozen of them over a course of my career, that would be a substantial amount. When we're using the term metastasis means that the cancer has spread from its original site to other sites. So typically in prostate cancer, we're going to talk about having clinically localized disease, meaning that the disease is local to the prostate, it hasn't spread outside the prostate. You can have local regional disease, meaning that the disease is in the prostate and then the tissues immediately surrounding it. And we're really talking about lymph nodes when we're talking about that. And then you can have metastasis. And for someone to have metastasis for prostate cancer, it has to spread above the lymph nodes that are outside the true pelvis. So that could be what we call the retroperitoneum, or the lymph nodes that are kind of surrounding the spine, the kidney, and other organs in the back, as well as the bone. The bone is a very common place for prostate cancer to go as well. And it's a little bit outside the scope of this talk, but as the disease becomes more aggressive or after multiple treatments, it can spread to solid organs like the liver, and that kind of necessitates that we change our treatment plan a little bit. So what type of symptoms may you have with clinically localized prostate cancer? The answer to that is really going to be none. Remember that we are trying to identify men with clinically localized prostate cancer by doing screening. And how do we do screening? Well, there's a lot of controversy in this area. If you kind of wind back the wheels of time about 10 years ago, one of the government agencies said, we shouldn't really be screening men at all for prostate cancer. The reason they came out with that is because we as a community, as urologists, were overdiagnosing and overtreating men. And that's something that we've really fully acknowledged and kind of gone back to the government on and say, listen, like, we understand that we were probably over-screening, over-treating men. But to not screen men at all is kind of an overreaction. And what we found over the past 10 to 15 years is that we were missing men with clinically localized disease and finding them later in the disease pattern when they had developed that local, regional, or metastasis, which at that point, it's that magic word of cure is off the table. Thankfully, with a lot of lobbying, the government agency kind of walked back their statement to saying that screening for certain age groups is appropriate. So there's a lot of different agencies out there that have different age ranges of which we should and shouldn't screen. The one that I and most of my partners hold on to is about the age of 55 is the time to start screening for most men until about our mid-70s. Now, why would we start screening men earlier? We would start screening them earlier if they have a strong family history of prostate cancer, especially if they have a first-degree relative that has died of prostate cancer or has at some point developed metastatic prostate cancer. Who would we screen over the age of, say, 72? Well, really, once you get past that age range, we're going to be talking about, and this is always a difficult conversation to have with patients, but what is their life expectancy? And what I like to tell patients is, I don't know how long you're going to live. The only one that knows that is the big guy upstairs or big female upstairs, depending on your beliefs, and they do not talk directly to me. And typically what we see in patients or humans as we age is there's some defining event that occurs, break a hip, get some kind of cancer diagnosis, something happens that kind of sets the clock. And when men kind of reach the point where we think their 10-year survival is limited, that's really when we should no longer be screening for prostate cancer. Why? Even if you got it, it's probably not going to get you. So most forms of prostate cancer are very indolent, meaning slow growing. So if you developed it, it's going to take years and years and years before it spreads, metastasizes. And even once it metastasizes, it's going to take years for it to finally lead to someone's death. And so if you take, say, a 75-year-old that maybe has some other medical problems, if they developed prostate cancer on their 75th birthday, chances are they could live to 85, no problem. Most patients in the US currently live to about 83. So you can see how you've kind of reached past that life expectancy standpoint. Now it's different. Some patients have really strong family genes, where people are living into their 90s or they're extremely fit. So that's why it's not a hard and fast, we're this old, we're going to stop. It's a conversation to have with your physician. A lot of the symptoms that are actually on this page, these are things that we always want to know about as your urologist. They're kind of a little vague, but can kind of help us steer the pattern. These could be things for urinary symptoms. It could be things for kidney stones, things we worry about for maybe bladder cancer, but prostate cancer as a whole, when it's clinically localized, is asymptomatic. Risk factors. We talked about age a little bit. So the average age is about in our mid-60s. Strong family history. You can see it occur earlier on. And so what are things that we would consider strong family history? Well, a first-degree relative that had metastatic prostate cancer, died of prostate cancer, or maybe even if your mom had a really bad case of breast cancer and had a gene positive called BRCA2. That's something that we'd want to know, because we'd probably start screening you earlier and maybe even consider getting genetic testing in you. Ethnicity. So if you look at old published data, African-American men have reports of having higher rates of prostate cancer and more aggressive prostate cancer at time of diagnosis. More recent years, this has been questioned, and really the question is this truly that African American men have more aggressive forms of prostate cancer, or is it an access to healthcare issue where they're not getting screened appropriately, and then we're catching them as they're having local, regional, or metastatic disease, and not earlier on where they have localized disease? That's something that it's a little bit of a hot topic in urology now, so maybe I'll better answer that in the upcoming months to years for you. Family history we went over again. Again, first degree relatives are something we definitely want to know. Obesity. Most cancers in general have increased rates of, or they are found at increased rates if we're obese. Now, again, questioning is, if you're obese, are you getting more tests done? So we're finding more things because you're utilizing healthcare more because of other health issues, or is there an actual way that's manipulating the cell turnover, gas pedal brake analogy that we used earlier? Not very clear for prostate cancer. Screening tools for prostate cancer. Well, all the men here are probably very familiar with this. There's two tests that we use commonly, and that's the digital rectal exam and also the blood test, the PSA test. Just give me 1 second to clear my throat. So of these two, the more important one is the blood test, the PSA. So let's start there. Let's first talk about how was PSA first utilized. PSA is a tumor marker, meaning that when we have diagnosed someone with prostate cancer and they have been treated for prostate cancer, we use a tumor marker to follow their disease to see how it is responding to treatment. When you talk about PSA as a tumor marker, it is one of the best tests ever developed. Now, we had this great idea years and years ago that let's move this tumor marker from when we know someone has prostate cancer and we're treating them, and let's move it over to screening men to see if we can predict who is going to develop prostate cancer. And therein lies the problem that this is a tumor marker study that we have tried to use to be a screening tool. What is the most useful way to use a PSA? Trend over time. So if you come in and see me when you're 60 years old and your PSA is 4, does that mean you have prostate cancer? I have no clue. There's a couple of tests we're going to do to try to help hedge our bets. We may get a prostate MRI, we may get a repeat PSA. We're definitely going to do the digital rectal exam and plus minus a biopsy. However, if I've been seeing you since the age of 50 and your PSAs have been 3.6 and eventually 3.7 and then 3.8 and then 4.2, that trend over time is that slope is very low. But when we see men and we've been tracking them year over year after year, and then all of a sudden they have this quick uptick, that's worrisome. And that could be, I have some men that their PSAs are 1.7, 1.6, 1.7, and then they come in and it's 2.5, 2.8, and we say, hey, that's a doubling, or sorry, it's an increase of 1. Like, what's going on here? And then we may consider a biopsy at that time. I have other men that are in my practice, their prostates are huge, like 120, 150 grams, and their PSAs are 13, and they're completely fine. It's all benign tissue. We've done biopsies, we've done the MRIs and everything to make sure we're not missing anything. They just have a big prostate. A little bit more detail about the PSA. It's a protein that's secreted by the prostate itself. That means that it's specific to the prostate. And this really gets back to that tumor marker, meaning if the prostate's dead or removed, it should be 0. And so that's why we can use the test to monitor your disease response. The last bullet point, we kind of talked about this, was as a high level. There's no normal. You will establish your own normal by being screened yearly. Let's talk about digital rectal exam. Not everyone's favorite part. It's still something that we utilize. It's hard to diagnose prostate cancer off of a digital rectal exam. If someone prostate normally should kind of feel kind of soft. So if everyone takes their hand and holds it up and you touch right underneath your thumb, kind of right here. That's how a normal prostate should feel. Now, if you take your thumb and you reach it all the way across to your pinky, and you feel how it's a lot firmer, that firm feeling would be more worrisome to me. However, in men that have really aggressive prostate cancer, it feels hard, almost like the knuckle of your finger. And that's usually not a good sign. And those men usually have very aggressive disease. They may have local, regional, or metastatic disease at the onset. But most men are going to feel nice and soft. Now, just because it feels soft, we have to use the PSA, because remember, that is the more important tool. And it's something that we want to track over time, not just cross-sectionally. Diagnosing prostate cancer. So the only way to diagnose prostate cancer is a biopsy. There's lots of tools that we use to try to obtain a better understanding of where we need to biopsy, who do we need to biopsy, and so forth. But the only way to diagnose prostate cancer is via a biopsy. And this is typically done where there's a transrectal ultrasound put in, or ultrasound that's put into the rectum. It's typically about the size of a poop or smaller. And then a needle that goes either through the ultrasound, punctures the rectal wall and into the prostate, or sometimes we'll actually do a transperineal, which means we put the needle, where the ultrasound probe's in the anus still, we put the needle through the skin that's in between the testicle and the anus, and you can get biopsies that way. Once we obtain the biopsy, that tissue is then sent out to the pathologist. They review it, and typically we get the results back in about 7 to 10 days is our typical turnaround. Now, there's the second bullet point here, something called the Gleason score. This is really complex for patients to understand. And Gleason, the name of the doctor that invented this score, was from Hopkins. He's since retired, I think, unfortunately, has moved in past. But there was another young guy, John Epstein, that went down to Hopkins and really took over his work. And he kind of came up with this idea of, we use this Gleason score to talk to patients about the risk of their prostate cancer. But the way that the score is made is crazy. Like the lowest you can get is 6. Well, why shouldn't the lowest be 1? And so what we have done as a community, and you will see this kind of take over in the next couple of years, especially as doctors get younger and younger and younger, because we've been the ones that have taught it, is to move away from the Gleason score to the Gleason grade grouping. And again, this is all just a play on numbers, but it's meant to make it easier to have a discussion with patients. So a Gleason score of 6 is now a grade group of 1. And then it moves on. So the lowest grade group you can have is a 1, and the highest grade group you can have is a 5. The higher you are, the more aggressive the disease is, and the higher risk category you will be placed in. We're going to talk about risk category in a second, so I'm just going to kind of leave that to a side. Other things that we want to look at are going to be when we're trying to take your biopsy results in a man that has prostate cancer. So biopsy results could come back and they could be negative. Best case scenario, hope we all get that. But in men that don't, is we have to risk categorize you. And that risk how we risk categorize you is going to help us determine what treatments are available to you. There are 6 risk groups for prostate cancer. And so we look at your grade group. Remember, that's how the prostate biopsies look underneath the prostate. Your PSA score, how many biopsies were positive for certain grade groups. If you got an MRI, does there appear to be cancer outside of the prostate? We call that extracapsular extension. And also how much, so if each core is, say, I'm going to make this up, 10 millimeters long, what percentage of that core is actually involved with cancer? There's some other tools that in men that unfortunately that are diagnosed with prostate cancer that you may undergo. So remember how we talked about those risk groups. There's 6 of them. There's something called very low risk, and then there's low risk. Typically for those patients, we will consider active surveillance, where we know that the disease is very indolent or it grows slowly, and it is not a type of prostate cancer that kills men. So we watch it. Why do we watch it? One, we want to make sure what we told you was accurate. So we're typically repeating a biopsy in a year. And two, we want to make sure that that type of cancer does not progress to something that could be more dangerous. So that's very low and low risk. Then you can have favorable intermediate and then unfavorable intermediate. These are typically men that when we offer them treatment, we are trying to intervene in a way to get them a cure. Lastly, you can have high and very high risk. Now remember, these are the more aggressive types of therapy. And typically, what I like to tell my men is that have very high or high risk prostate cancer is we need to think of this as a chronic disease, something like high blood pressure or diabetes. More than likely, one treatment modality, surgery, radiation, is not going to be enough over the course of a lifetime. More than likely, the disease will come back and we will need other modalities of treatment to prolong your life. Now, in men that have unfavorable, intermediate, high risk, or very high risk, we have to get certain staging studies on them. Staging studies allow us to understand, do you have localized disease? Has this disease potentially spread outside the prostate to the surrounding lymph nodes? We call that local regional. Or has it potentially spread outside of that region and metastasized? Conventional imaging, which is what most men will get, includes a CT and a bone scan. The CT scan is going to look at some of the bones in your abdomen and pelvis, but it's really looking for enlarged lymph nodes, especially in the pelvis. The bone scan is a study specific to the bones, where we're going to try to see if we see cancer in the bones. At Wynwood, we try to get both these studies done at the same time or on the same day, just to kind of condense things and make it easier from your experience. That can't always happen, but that's, Patty and Carol are usually pretty good at trying to line those things up. In my practice, I've really moved away from getting CT scans. I know Dr. Ahn, Dr. Hag, a lot of times we'll still get that conventional imaging, but we're trying to move away from that to really getting MRIs. And the reason for that is, the CT scan, again, is going to help us with enlarged lymph nodes. Well, an MRI is actually better at looking at soft tissues, lymph nodes, to see if they are potentially harboring worrisome disease. Also, if we're considering surgical intervention, I really want to look at an MRI that really helps me with surgical planning prior to the operating room, because not every case is exactly the same. We have to tweak it a little bit to kind of tailor make it for each patient. And most surgeons, myself included, we want to know everything we can potentially know prior to entering the operating room. We don't like surprises. We like plain old vanilla every single day. The last test listed here, or the PSMA scan, this is really, in my opinion, this is going to change how we treat prostate cancer in a very positive way. So the PSMA scan is a PET scan that is specific for prostate cancer. So how a PET scan works is you have some kind of ligand or something that attaches to something in the body. This ligand only attaches to tissues that have PSA. So it's specific to prostate cancer. That ligand then has a molecule that glows on it. So when you go through the CT scan, wherever this molecule attaches glows bright. And it is more specific for finding metastatic disease than a CT, bone scan, or an MRI. So it is allowing us to more properly risk stratify men or stage them. Do you have clinically localized, local, regional, or metastatic disease? And then provide them appropriate therapies. But two, what we're going to talk about in a couple slides from now, that scan is actually being linked to therapy. So remember, the first part of that scan is that you have that ligand that binds to prostate cells. Well, instead of attaching a marker that glows to it, what if we can attach therapy to it? So we can give you therapy at a cellular level. and that's called Pluvicto. And that's something that came on the market. It just completed clinical trials maybe a year and a half ago. And it's something that MidLantic now offers. So that's great. We can really provide cutting edge medicine in the community, which is wonderful. The stage assessment, when again, these are slides that we use throughout all MidLantic. I think we've kind of been through this a lot where we're talking about clinically localized, local, regional, or metastatic disease. Strictly speaking, whenever we're staging someone, we're always doing what's called a TNM. T stands for the tumor, N is nodal involvement, and M is metastasis. This is really language that we use to communicate from provider to provider. So, specifically like in my bladder cancer patients, it's really important to know, are we going to give them chemotherapy prior to surgery, after surgery, and for me and the medical oncologist to talk back and forth. For prostate cancer, it is used, but we really talk about it in very different ways as well. More, especially when we're getting to advanced cancer stages, whether it's hormone sensitive, castrate resistant, metastatic castrate resistant, non-metastatic castrate resistant, which is, it's beyond the scope of this talk, a better talk for ones in the future. But now TMM. All right, so what's best from a prostate cancer treatment overview? This is really, there's a lot of data that looks into this. So I think the best way to start with this conversation is with someone that has clinically localized disease. Now, in someone that has clinically localized disease, the treatment options that are going to be available to them are going to include potentially active surveillance if they have that low or very low risk prostate cancer, maybe surgery and radiation, maybe even focal therapy. We'll go through all of those in a little bit more detail. There's one study, it's an old study, and that looked at the difference between surgery and radiation. And, at this point, this study's going to be like 15 to 20 years old at this point. And it found that in younger men, specifically under the age of 65, they lived longer if they got surgery up front. Now, I would tell you the kind of argument to make to that is that study was done 15 years ago. The way that we do surgery has changed 10 times over, and the radiation machines have gotten much, much better. So is that study still applicable in today's setting? I don't think so. But if your doctor talks to you about younger men getting surgery, that may be the study that they're referencing. Really, the way that I like to counsel men is that this is a very personal decision choice. And when you look at the most recent data, when you're talking about overall survival, and that's what matters the most, right? How long are we going to live with a cancer diagnosis? And you look at the difference between radiation and surgery, people live about the same. There's no significant difference. Really, what you have to understand is the risks associated with each form of treatment. And in men that are going to need potential sequential treatment, remember we talked about those men that have higher risk disease, that which therapy we do first may impact the therapy that we do second and then third and then fourth. So that's something to also consider. Now, getting a little bit more into the weeds with active surveillance, again, that's typically something that we offer to men with very low or low risk disease, sometimes with favorable intermediate risk disease. This is where we're actively monitoring you. We're not intervening. And we're looking to make sure, one, what we've told you is correct, and then two, to make sure your disease is not progressing. And our current follow-up for that is to get a biopsy, let's say January 1st, to make the dates easy to understand, and you're enroll in active surveillance. 6 months later, so in June, you're going to come back and see your provider, get a digital rectal exam, get a PSA prior, and make sure your PSA is relatively stable. If your PSA has jumped considerably, then we may say, hey, let's repeat a biopsy now. But if things look stable, then we really try to get a repeat biopsy at that 1 year time frame. That's standard of care. Surgical therapy. This is where we're going to remove the prostate and then reattach the bladder to the urethra so a man can urinate normally. About 90% of these surgeries that are completed in the United States today are done robotically. That is really the preferred way to have it completed. Why? It's better for you as a patient. Better outcomes, shorter hospital stay, quicker time to recovery, and better functional outcomes. So when we talk about functional outcomes, we're talking about erectile function, and we're talking about urinary continence, or being able to hold on to your water. Open surgery, if you're or patients had their prostates removed in an open fashion, there's a couple ways to do that. You could do it through a lower midline incision, which is where there's an incision from the belly button down to the pubic bone, which is the bone that's right above your penis. Or you can do it via a perineal, which is the area between the scrotum and the anus. Both ways were popular. They both did the job, but again, they really have been replaced by robotic surgery. And the robot's really been popular for probably the past decade to 12 years. Side effects to be made aware of for any type of surgical intervention on the prostate is urinary incontinence, and this is where you leak urine. Now, there's a couple ways to remove the prostate when you're talking about having robotic surgery, and all the new forms, or the things that we're trying to move the needle on, are trying to improve these functional outcomes without jeopardizing the cancer outcome. All right. So remember, if we go in to do surgery, our greatest thing is we want to control the cancer while also balancing the urinary and erectile function. So we kind of always talk about it as a triangle where each point is important, but at the peak of that is the oncological outcome. We're getting the cancer out without leaving it behind. So one of the newer ways to perform this procedure is something called a Retz's sparing procedure, and Retz is the name of a doctor that named a space that's in the body. But really, we're not manipulating a lot of the tissues. We're leaving a lot of the tissues in their natural place without disturbing them. And by doing that, what we've found is that the patient's time to recovering their ability to hold on to their urine has drastically improved. Whereas if we manipulate all those structures, like dropping the bladder, it can take up to 6 to 12 months to really regain your urinary control. By doing it without manipulating all those things, sometimes when we take the catheter out 7 to 10 days later, you're completely dry, but we really like to see you be dry by 3 months. So we've been able to move the needle up with that. How surgery will impact your erectile function, that's really a conversation to have with your surgeon, and where they see. That's one of the reasons I really like to get the MRI, so I can kind of tailor approach and also appropriately educate you about how much I think the surgery is going to impact your erectile function. In kind of broad strokes, if you come to me and you have good erections going into surgery, you're probably going to have decent erections coming out. You're probably going to have to, for the first couple of months, use things like Viagra or Cialis, do a little penile rehab. But I'd like to see you regain your erectile function. If you're already using agents like Viagra or Cialis, you're probably going to be dependent on them or need a higher dose after surgery. And if you have really poor erections going into surgery, I'm certainly not going to help that. I'm not a magician. I'm not going to turn that around. There's definitely things that we can do to address that as well. Again, beyond the scope of tonight's talk, but something that we can definitely talk to you as well. Radiation. So radiation is typically talked about as external beam radiation, where this is remember, I'm not a radiation oncologist here, so this is very, very dumbed down, but we're going to be passing beams of energy from outside your body into your body. Those beams of energy are going to be aimed at one body part in particular and destroy that tissue and the cancer within it. So in terms of prostate cancer, we are going to direct those beams of energy at your prostate, your seminal vesicles, and the lymph nodes, perhaps, depending on your risk group, and destroy those tissues and the cancer within it. Risk factors for radiation, kind of the opposite when we talk about it from a urinary standpoint. While you're getting radiation, you can almost have the feeling of needing to go too often, or urgency, like a gotta go type feeling. Thankfully, that typically goes away after you're completed the radiation, and it's all just from inflammation. You can also get that feeling in the bowels or the rectum. Unfortunately, if you get that, not all men do, but if you get that feeling does not go away after radiation most of the times. So to help prevent that, we actually, in almost all patients at MidLantic, will get something called a spacer. And that's piece of jelly that we inject between the prostate and the rectum. It increases the space between the two. And how radiation works is that the further you are away from that beam, the less energy gets deployed to that area. So even increasing something by a centimeter and a half drastically reduces the amount of energy that gets passed. So if we pass the beam of energy from front to back, hits your prostate, and that space door is behind the prostate by a centimeter and a half, it's going to decrease how much radiation your rectum gets to avoid those symptoms. Erectile function will also be impacted by radiation, so it's not something to avoid on that. Very similar to surgery. Some studies would suggest maybe a little less, but again, the best predictor of what erections will be like after any intervention is what they are like going into the intervention. Focal therapy. So for the most part, focal therapy is still experimental. I do think that we're going to see it be used more in probably the next decade. Who's really probably an appropriate gentleman to have focal therapy, in my opinion? Again, this isn't really all flushed out. It's probably someone that has clinically localized disease and has either low risk or favorable intermediate risk. So why would we treat someone with low risk? Remember, I told you most of those men we try to get on to active surveillance. If that patient was just too nervous to stay on active surveillance and they only had one section of their prostate that looked worrisome, we could try to just treat that area. And someone with favorable intermediate risk disease, again, we typically treat those men. Very seldomly do we put them on active surveillance. But again, if it was localized to only one part of the prostate, you could try to treat just that part of the prostate. The current modes that are FDA approved are ultrasound, which creates heat and destroys the tissue, or by sticking needles through the perineum. Again, that's the space between the testicles and the anus, and using either hot or cold to destroy the tissue. Hormone therapy. So hormone therapy is typically used in men that have unfavorable intermediate risk prostate cancer, high risk, or very high risk prostate cancer when the disease is localized to the prostate. In men that have local, regional, or metastatic disease, hormonal therapy is the mainstay. Why? Well, hormonal therapy decreases the male sex hormone testosterone. Testosterone, a direct protein that's secreted or comes from the pathway, is PSA. So if we decrease your testosterone, we're going to decrease the amount of PSA that your prostate or prostate cancer produces, and therefore kind of put the brakes on the disease process. The hormone therapy comes in multiple different forms. The most common form is an injection form, and it's given in what's called a depot. Depot means that it will last for a certain amount of time. It either comes in 1, 3, 6, and I think some of them come in 9 months. 3 month is usually the most common depot, because we're typically seeing you every 3 months. Some people that are what's the word I'm looking for? Snowbirds, whether they go to Florida or Arizona, sometimes they want the 6 month depot. You can also get it in pill form. There's a new medicine called Orgovex that we have via our pharmacy that we can get you. It avoids the injections, but you do have to take it every day. And then there's also advanced pharmaceuticals, which are kind of like, think of them as the hormonal therapy, but on steroids, or the supercharged ones. And those are really only for patients that have really aggressive disease. And all they do is they really further decrease the testosterone levels even further, therefore putting more brakes onto the cancer pathway. Side effects of hormonal therapy, well, these will definitely be felt. It's best summarized as almost going through like a male menopause. So you can get hot flashes. You're going to have some weight gain, loss of muscle mass. You can get some nipple tenderness. You can even get some gynecomastia, or enlargement of the breast tissue. that will get better with some time. There's definitely other therapies that we can give you to help mitigate those side effects. Some men will also complain of lethargy or tiredness. And another thing to also be aware of is it can decrease your bone mineralization. So another thing that, if you're on any of these agents, is to make sure you're taking a calcium and a vitamin D supplement. All right. Some other forms of therapy. Now, we don't use a lot of these when we're talking about clinically localized prostate cancer. But immunotherapy is going to be, it's a play on recruiting your body's own immune system to help fight cancer. Remember at the beginning of the talk, we talked about how cancer is about how cells are rapidly dividing by either having the gas pedal stuck down or the brake pedal stuck up. The immunotherapy works to try to help reestablish an equilibrium. There were some early trials of immunotherapy with prostate cancer that weren't too promising. There's other cancer types, lung cancer, bladder cancer, melanoma, that respond really well to immunotherapy. And it's really, you're looking at the mutational burden. The higher mutational burden, the greater response you'll have. Prostate cancer, unfortunately, just thus far hasn't been the best responder. Targeted therapy drugs. I'm not really sure what they want us to talk about on that, but that's really going to be your hormonal therapy, those advanced drugs for men that have advanced cancer, prostate cancer. That's going to be things like abiraterone, Xtandi, Erleada, and a couple of others, Nubeqa, that are available as well. Again, all those do is lower the testosterone even further. Chemotherapy. The current forms of chemotherapy that we use in prostate cancer is really docetaxel. There's also carbazetaxel, but most people get docetaxel. And that's typically given further along in the disease process where you have metastatic disease that is no longer responding to androgen deprivation. There was a new data that came out probably about 4 or 5 months ago at this point. They looked at men diagnosed with newly metastatic disease, meaning they came into the office. And when they came into the office, we found that they had metastatic prostate cancer. And if we give them hormonal therapy, so like the shots, and we give them a super hormonal agent, either abiraterone or Nubeqa, plus chemotherapy, they actually do better up front. So that's something that we're also shifting our pattern to as well. If, unfortunately, you are one of those patients or your family member is, it's something that we partner with our medical oncologists with. We do not give the chemotherapy. We give the androgen deprivation therapy and kind of that super ADT, and then allow a partner with the medical oncologist for the chemotherapy. Radium-223. This is an injectable agent that can be delivered to treat men with metastatic disease that's mostly in the bone. You can have some adenopathy, but mostly bone disease. And it's been shown to, one, help with pain, but then two, also improve how long you live. And then this last one, lutetium, Lu-177, otherwise known as Pluvicto. This is really that exciting drug I was talking about earlier that's linked to that ligand and the PSMA scan where it glows, but we remove that glowing portion, and then we attach this targeted therapy where it's delivered to every cell in the body that takes up that ligand. So it's kind of localized therapy all over the body. And this is only my opinion, but I think we're going to see this be used more and more and more, and even earlier in the disease state. Currently, you can only get that therapy after you have received chemotherapy. But I think in the next 5 to 10 years, we're going to be seeing it used much, much earlier. Supportive care. So I think this is probably one of the most important slides in this whole deck. Whenever I am talking to a man about an elevated PSA and we're talking about needing a biopsy, I'm always excited when I see them back to review the biopsy results and they have a family or friend. It's so much information. It's so overwhelming. Your life could be potentially turned upside down. You need 2 sets of ears, 2 sets of eyes to really take this all in. And not only that is, you're spending, if I see you to talk about your PSA, do the biopsy, and then go over the results, I'm maybe spending an hour total with you to try to give you all this information. But whoever your supportive care person is spending your life with you, sharing it with you. And so for them to understand the diagnosis, the treatment decisions, the potential complications or the side effects, I think is monumentally important. And I think most of my partners and all the docs at MidLantic share in that sentiment as well. So please don't ever be afraid to bring them. I have some that come in because they just want to be just me and them when we go over the biopsy, but then I just bring them back a week later and I sit down with their family and friends as well. We're happy to do whatever we need to. What about research? We touched on a bunch of this stuff earlier. So we talked about genetics. So there are some genes that we know that one can increase the risk of developing prostate cancer. Not only developing it, but getting an aggressive form of prostate cancer. Also, there are some forms of therapy, specifically what we call PARP inhibitors, which technically you could maybe put into the immunotherapy bucket, that are available to patients that do have a BRCA2 mutation. Now, that's not going to be a lot of patients, but there are those patients out there. And that's how genetics is being used to kind of tailor, 1, screening, and then 2, treatment-related decisions. So I'll look at my notes to make sure I'm not missing anything about the precision. I think what they're trying to get at is here. So, while we talk about prostate cancer as the whole, as men in general, really when it comes down to your treatment, it's going to be individualized, and there's a lot of things that go into that. All right, now let me see if I can work the questions part here. Give me a second. So, I think one patient asked if I was telling them, because they're older, do they only have 9 more years to live? No, not at all. And that's why it's important for you to have a conversation with your individual provider to understand when should we stop screening. It's impossible for me to know all of your exact other health issues, and are you in good health, bad health, but that's when we, from a guideline perspective, the American Urological Association, American Society of Clinical Oncology are kind of told, hey, you should start having the conversation about PSA cessation or stopping PSA screening. It's called Rhesus sparing. So it's RETIZUS, Rhesus sparing, RETIZUS, Rhesus sparing prostatectomy. And that's something that I do based out of Lincoln. Ilya Zelter does at Bryn Mawr. A couple of the guys do it up and down the East Coast. But it really helps a quicker time to recovery from a urinary standpoint without impacting your oncological outcomes. Oh, so this is a really good question. So what can cause a 25% jump in PSA blood screen results over a short period of time? I didn't go over this. I'm really happy to answer this. So remember, PSA as a screening test is not great. It's not how PSA was invented. It was more as the tumor marker. So an acute rise in PSA can be from anything that causes inflammation. So say if you have an infection, UTI, if you have prostatitis, if you had intercourse the night before. There's some like theories if you go out on a bike ride that could cause it. I don't know, maybe you're biking like in the Tour de France. But anything that can cause acute inflammation in that region will cause more PSA to be excreted. So kind of put this into clinical context. Say if I saw a man that was on active surveillance or even an annual visit for PSA screening, and their PSAs had always been steady, and then there was this acute rise. I would ask them, hey, did you have any weird urinary symptoms when you get the test done? Did you go away with your spouse and, maybe have more intercourse than you normally did? And if anything raises a suspicion that that test may not be valid, then we just quickly hit the pause button. I have you go get a repeat PSA. If it comes back down, that's good. But if it's up that high again or higher, that's going to only raise my concern. And in really general concepts, if you're in a man, your PSA should go up slowly. If it's going up fast, it stays up, that's going to be something that we're really going to worry about. But in a normal man, you're not going to see these really abrupt rises that stay up and stay going up and up. PSA, prostate specific antigen. PSA is prostate specific antigen. And that just means that it is a protein that you can find in the blood that is specific to the prostate. That's why, like, if we remove your prostate, your PSA should be 0. So diet. So in terms of decreasing your prostate cancer risk, there has not been any diet proven to decrease that risk from a randomized clinical controlled trial. So I cannot medically tell you eating more of this, eating less of this is going to lower your risk of prostate cancer. But I think you can say that if you're eating a well-balanced diet, also maintaining some form of physical exercise, and are in overall good health, that's only going to help you from a global health standpoint. And kind of as an aside, like, we're talking about prostate cancer tonight, and obviously, of the people here, this is probably touching either you personally or a family member. But the most common reason that men and women die in the United States is cardiovascular disease, not cancer. It's cardiovascular disease. So a healthy diet is only going to help reduce that leading risk of death. I'm going to give it a couple more minutes to see if any other questions come in. But before then, I just want to thank everyone for logging in. And if there's any other topics you want to hear about from a cancer perspective, most of what I do in the Wynwood office is with regards to cancer. Please let us know. I'd be happy to do this again. We can also go into more detail about, we really went over prostate cancer at a 30,000 foot view today, but we could go over it in much more detail in a specific subsection if you want. Talk about bladder cancer, kidney cancer, whatever you guys would like. Last question coming in. Oh, actually, there's a couple here. So cells that naturally kill cancer cells. We're talking, so this is when we're getting into immunotherapy, how we combat things. Sorry, there's a bunch of questions coming in. I'm getting distracted. So immunotherapy really plays on using your natural immunity to fight cancer. So you're looking at things called your T cells, your dendritic cells, or your NK cells. And those are all forms of white blood cells that naturally fight off cancers or diseases, sickness, viruses. The problem is that cancer, as it evolves, finds ways to evade those cells. It's crazy stuff, but when you think about it in simplistic terms, like, this cancer is a living thing. It's not you. It's something different. It's trying to find a way for it to survive as well. So it's always changing and adapting as well. And so some of the most common forms of immunotherapy actually work to fight against common ways that cancer cells evade the immune system, thereby allowing those dendritic cells, NK cells, T cells to then locate and kill the cancer. Is the PSA an initial gateway test for prostate? It is the initial test along with the digital rectal exam for prostate cancer screening. Now, remember the prostate, you can also have lower urinary tract symptoms, which is going to be more prostate enlargement. And that is incredibly common in men. By the time that we all reach 80, it's like ubiquitous. The way that we're urinating has changed substantially over time. But that is not the change in the way that you pee is not necessarily a hallmark of prostate cancer. They're the same organ, two different disease processes. Would removing the testicles lower your PSA? Yes. So that's called surgical castration. So when we're talking about androgen deprivation therapy, or we're talking about the injections, the pills, or the kind of the super up pills, those are all forms of medical castration. Prior to any of these things existing, not me, I didn't practice back then, but they would just castrate men and remove the testicles. Still something that you could get done today, by the way, if you wanted to, if you didn't want the injections or the pills. It's a hard sell, though. All right. Well, I want to thank everyone for coming. I'm going to run upstairs so I can put my little one to bed. But for those of you I see in the office, I'll see you soon. For those of you to see some of my other partners, I'll see you around as well. Talk soon. Bye-bye.
Thank you again for joining us. I hope you've learned something today. We appreciate that you've placed your trust in us. If you have any concerns or would like to make an appointment, you can call us at Keystone Urology at any time.